All right, well, now we get to move on to one of the highlights of our meeting. I have the pleasure of introducing this year's SCVS Distinguished Visiting Professor. Michael Conti is Professor and Chief of Vascular and Endovascular Surgery at the University of California, San Francisco Medical Center and holds the E.J. Wiley Chair in Vascular Surgery. Mike is a native New Yorker and attended medical school at Albert Einstein, followed by a surgical residency at Cornell. He completed vascular surgery fellowship at Brigham and Women's Hospital in Boston and joined the faculty at Yale New Haven Hospital in 1994, just as I started my third year there in general surgery residency. We worked together for 3 years before I left to start my vascular fellowship, and he then returned to the Brigham as faculty for 11 years, finally moving west to his current role at UCSF in 2008. During those 3 years at Yale, Mike inspired me toward a career in vascular surgery. His passion for our specialty, especially limb salvage, was palpable. He is a surgeon scientist with focus in peripheral arterial disease and vascular repair. His research has been funded by the NIH for over 20 years, spanning basic and translational science to clinical trials. He has authored over 250 peer-reviewed publications and has led international practice guidelines on PAD. Mike is past president of the Western Vascular Society and past chair of the AHA Council on Peripheral Vascular Diseases. In the wake of the BEST trial results, I asked Mike to speak to us on the current status of revascularization for critical limb-threatening ischemia, and I'm ecstatic that he agreed. Ladies and gentlemen, Michael Conti.
Thank you, Sean. It's truly a privilege and a pleasure to join you for the 50th meeting. It's nice to be back at the SCVS, and congratulations on your presidency and really an outstanding meeting in a wonderful venue. I'm going to share with you some of my perspectives here on evidence-based revascularization for limb-threatening ischemia. And this is a topic that I've spent quite a bit of my own time thinking about over the last 20 years. And we're really at an exciting moment, I think, to move this field forward. So these are my disclosures for this talk. I think everybody in the room realizes that peripheral artery disease continues to grow across the world because of the aging of the world's population and the growth of diabetes, in addition to the ongoing risk factors of hypertension, smoking, and hyperlipidemia. In the current millennium, it's estimated that over 200 million individuals somewhere in the world have peripheral atherosclerosis. And this is a major global health problem with serious implications for public health systems around the world. And if we estimate that somewhere between 5 and 10% of these people have limb-threatening ischemia, it's a big number of patients that are coming at us and what we're dealing with in our practices every day and will be for many years to come. It's also a disease that poses great risk not only to limb but to life. You can see from this graphic that if you look at patients with chronic limb-threatening ischemia or those who have had even a minor toe amputation as well as major amputation, their 5-year mortality exceeds that for almost every cancer except for lung cancer. So these patients are at high risk for limb loss but also for cardiovascular events and mortality, and they require aggressive and effective therapy to reduce these risks. So what are we talking about with evidence-based care, evidence-based medicine, and evidence-based revascularization of all things? We understand that in all of our biomedical literature, there is a pyramid of the quality of evidence that drives how we practice. And for the most part in surgery, we rely a lot on the lower third of this pyramid with a lot of cohort studies and case series to drive the evidence around which we do. And much of what we hear about at this meeting, frankly, is that. And that is okay because that's the kind of evidence that we can get. But the best evidence to demonstrate the effectiveness of therapies is generated by controlled trials, particularly randomized controlled trials. And the highest level of evidence is when you can assemble multiple trials with systematic reviews, and meta-analyses that can be then used to drive evidence-based clinical practice guidelines. But most surgeons kind of take this approach to evidence. You know, we base what we do mostly on our individual experience, the biases of our training, sometimes the last 10 cases, and how they turned out, and we may be a little bit resistant to the concept of evidence in terms of how we should apply it in everyday practice. Indeed, much of us practice based on anecdote. The plural of anecdote is not evidence. Evidence requires study and clinical science. And evidence creation in medicine, and especially in surgery, is difficult and arduous, but it's necessary to improve patient care. And I hope I can convince you today that as vascular surgeons, we can both innovate and drive evidence at the same time. And I think the roadmap for that is ischemic heart disease, that it is indeed possible to generate increasing degrees of high-quality evidence that drives clinical practice while continuing to innovate and develop better and better technologies. Certainly over the last 50 years, the evolution of treatment of coronary artery disease has changed dramatically with drug elution, better devices, and also advances in cardiac surgery. Many clinical trials have been conducted comparing medical therapy to coronary revascularization and comparing open surgical revascularization to percutaneous interventions such as stenting. I'm just highlighting one here from the Syntax investigators for a specific reason. This is an example of the kind of high-quality studies that have been conducted in ischemic heart disease that we should be inspired by. And what the Syntax trial showed, among other studies, was that there is an advantage in many patients to coronary bypass grafting over PCI with regard to specific endpoints, such as the need to repeat revascularization and the incidence over time of major adverse cardiac or cerebral vascular events. But most importantly, what the Syntax investigators did was they looked at anatomic complexity of disease treated, and they developed a specific score. And you can see on the right-hand side that as the complexity of disease goes up, the advantage for surgery increases. So the Syntax trial demonstrated that disease complexity in ischemic heart disease defined the advantages for surgery over PCI and allowed cardiologists and cardiac surgeons to begin to offer things to patients that were based on evidence and based on their anatomy. So currently, clinical practice guidelines in cardiac disease have the advantage of many randomized clinical trials to draw upon. As a result, they have many Class 1 recommendations for the treatment of a stable ischemic heart disease, stratified by things like the coronary disease pattern, the presence of left ventricular dysfunction, and looking specifically at outcomes such as survival versus symptoms. And they stress the importance of informing patients in shared decision-making about the evidence and about these factors as the trade-offs between risks and benefits of invasive therapies are discussed with patients in a true heart team modality. This is the roadmap, I think, for us in the future in peripheral artery revascularization. And as you can see also from their guidelines, with that kind of evidence, they can create an algorithm that has specific situations where coronary bypass should be preferred over PCI, and where it might be acceptable to do one versus the other based on the type of patient, the candidate, the severity of the anatomy, and the LV dysfunction, and also the Syntax score. Again, using data to drive an understanding of what's the best revascularization approach for each individual patient with stable ischemic heart disease is now the standard of care. So let's talk about what we've accomplished as a specialty in the arena of limb salvage. And I truly believe the history of limb salvage surgery is one of the greatest contributions made by our specialty to the public health. And we stand on the shoulders of numerous giants in this field as we move into the current millennium. Over 70 years ago, Dr. Kuhnlin, a French surgeon, first showed the utility of using the saphenous vein to bypass occlusive disease in the lower extremity in the leg and demonstrated the technique of saphenous vein bypass. Within about 20 years, it was starting to be adopted in many centers around the world and also in the United States by many different surgeons and pioneers. I'm highlighting Dr. Manick, one of my previous mentors, who was an apostle of Dr. Linton, who was one of the early original adopters of vein bypass surgery. And the point is they began to demonstrate that a vein bypass could actually salvage limbs of patients with advanced ischemia. This was not a foregone conclusion. I also want to recognize the critical contributions of Dr. Lagerfo in the area of diabetic foot care, who demonstrated that although diabetes is a microvascular disease, that bypassing the macrovascular disease could actually save limbs successfully. This is a huge defeat of a myth that previously existed about diabetes being an end-stage microvascular disease that could really not be treated. Of course, in the last 25, 30 years, we've had a tremendous revolution in endovascular technologies with the development of wires, catheters, balloons, stents, atherectomy devices, covered stents. We now have so many opportunities to treat advanced atherosclerosis in a minimally invasive fashion that it's totally revolutionized our field. And so in the beginning of this millennium, we began to be faced with this debate and quandary about what we should do in which patients. We had the increasing availability of so many tools to be able to open up arteries in the leg more aggressively with non-invasive or minimally invasive percutaneous strategies, and yet we still had tried and true vein bypass surgery that was available and widely accepted. And I think the questions really that we were struggling with and are still struggling with is not whether or not we should use one exclusively versus the other, but really what works best, when, and in whom. It's very clear, I think, that solving these patients' challenges and their clinical problems requires a thoughtful and structured approach to staging the disease, to assessing the risk of each individual patient, and to be flexible and skilled in all of these revascularization strategies. But what we really have needed and still need is, rather than sort of the Wild West of doing anything that you feel like doing at any moment in time, is more of a systematic approach, similar to what's happened in coronary artery disease. And to do that, we have to do the work of generating the evidence. So what I'm going to share with you today is a little bit of what I see as the major signposts along this chronology of developing an evidence-based approach to treatment of advanced limb ischemia, starting in the 80s when centers were widely developing revascularization using open surgery, and ending at the moment with the BEST CLI landmark trial just published earlier this year. And a couple of key points along the way. I don't know why this is not advancing. Okay. In the mid-1980s, with the development of vein bypass surgery being accepted around the world, really, it became necessary to start to define how we were going to measure the outcomes. What were the important definitions and endpoints? And so the SVS first published its reporting standards in lower extremity ischemia by Dr. Rutherford in 1986. And then this was revised again in 1997 to reflect several iterations of improvements in analysis that became imperative. And during this era between 1980 and 2000, we had many reports of high-quality single-center registries that were designed to look at the long-term outcomes of patients who underwent bypass surgery, incorporating ultrasound surveillance. We also had critical randomized trials looking at different graft materials, such as vein versus prosthetic, during this era. In 2005, we had the first randomized trial comparing open vascular surgery to endovascular with the BASIL trial, and in 2006, the PREVENT 3 trial, which is a large trial of vein bypass surgery. We'll go through some of this data. In 2009, the Society for Vascular Surgery published objective performance goals to try to standardize some of the endpoints that should be measured for patients with critical limb ischemia and in those trials. In 2010, the BASIL long-term results were published. In 2014, the SVS published the Threatened Limb Classification System to enhance the staging of patients with this disease so that we could start to compare things appropriately with a common language. And in 2016, we had the SVS reporting standards for endovascular interventions. All of these steps are necessary to generate the definitions that you need to create the framework for evidence-based revascularization. And in 2019, the Global Vascular Guidelines came out with a new framework, which we'll discuss. And finally, in 2022, the publication of the landmark BEST CLI trial, which we'll talk about later in this lecture. So hark back to 1986 when centers around the world were doing lots of open lower extremity bypass surgery using a variety of techniques, a variety of conduits, and trying to really compare the results. And Dr. Rutherford led the way with reporting standards, and he highlighted the fact that, in essence, if we don't have standardized reporting practices, our literature will be a mess. We really won't know what worked well in whom, so we need to get much more rigorous about how we report our data in the literature. And this one article has been cited so many times, it's been the landmark of how we began to talk about lower extremity revascularization. Now, Dr. Veith has made innumerable contributions to the field of limb salvage surgery, and he has, in fact, at times disparaged randomized trials, but this is perhaps one of his greatest and most referenced articles, which is a multi-center randomized trial that was conducted and led by him comparing autogenous saphenous vein bypass to PTFE grafts for patients with advanced limb ischemia. And what this study clearly showed is here for femoral to popliteal artery bypass, that saphenous vein grafts are significantly superior to prosthetic grafts. And I will point out to you, when you think about the kind of literature and information that we look at today, that this did not become obvious until 24 months. So studies that don't have good follow-up are not able to really assess the durability and differences between these types of interventions. And here for tibial bypass, it was even more striking and obvious early that the saphenous vein is the gold standard for lower extremity bypass and clearly is superior to the use of a prosthetic graft. In 1997, as I mentioned, the SVS updated its reporting standards, and this document included a variety of improvements, including specifications about how data should be analyzed. But what I wanted to point out on this slide was the Rutherford classification scheme, again shown here, is often misused. And this is the original report showing that Rutherford 6, which is sometimes used in different ways in different studies, was meant to designate a functional foot no longer being salvageable. What that means is that the extensiveness of tissue loss in a salvageable foot was all included in Rutherford 5, which makes it a very, very wide spectrum of disease in those reports. A couple of other points and truths that we learned during this era between the 1980s and the early 2000s were that many centers published their data, this is from Brigham and Women's Hospital, on institutional single-center registries focused on careful follow-up using duplex ultrasound surveillance to get good long-term data on the durability of vein bypass surgery. And so durability was an important marker of success. And I think what we learned through these studies is the same in every case, is that vein bypass grafts have a three-phase curve of failure, where the first phase is technical, usually in somewhere between 5 and 8% of patients within 30 days having a problem. The biggest issue comes up within the first 18 months, where lesions develop within the graft from intimal hyperplasia, and then the process tends to stabilize so that beyond 24 months, the rate of failure is only about 3% a year, and this is mostly felt to be due to disease progression and atherosclerosis. This curve looks the same in every one of the studies that you'll see from the large series, but we learned a lot about studying the results of vein bypass carefully, longitudinally, with objective measures such as ultrasound surveillance to demonstrate what was happening over time. And in fact, I would suggest that we learned more about vein bypass grafting in the leg than the cardiac surgeons were able to in the heart because of the availability of ultrasound to follow what was happening exactly over time. Another important point is the issues around non-randomized studies and limb salvage as an outcome. So this is data from one of the early studies looking at a drug therapy, which is a prostaglandin analog. This is a harbinger of cell-based therapies and gene therapies, non-revascularization therapies to save the limb. It's a Circulase 1 trial. And I'll just point out that these were patients that were supposed to be no option for revascularization. They were enrolled in a randomized trial, 379 of them, and their limb salvage rate at 6 to 12 months was 87%. Now, that doesn't mean that every patient with CLTI who comes to you is likely to have a limb salvage rate of 87% with basically, there was no difference with the medical therapy, so this was basically best medical therapy. But what I want to point out is that limb salvage alone is a very insensitive measure of the quality of revascularization. And also, please keep this data in mind when you're looking at, and we'll continue to look at, the results of non-comparative trials or registries where amputation or amputation-free survival is the only measurable endpoint, because the natural history of these patients is quite variable and can be as good as 87% with medical therapy alone. Okay, so now we enter the arena of the randomized clinical trials with the BASIL trial conducted in the UK in the late 90s and early 2000s. Really, this was a landmark trial, a landmark effort led by Andrew Bradbury and his colleagues. and was the first to really compare bypass versus, at that time, percutaneous balloon angioplasty in patients with severe ischemia of the leg. This was first reported, the early results were reported in The Lancet in 2005. And then in 2010, their long-term results were published in a dedicated supplement of the Journal of Vascular Surgery, where several papers summarized all of their long-term results, both by intention to treat as well as by treatment received, and demonstrated some of the key findings, which we'll talk about very briefly. And I was actually asked to provide a commentary in that supplement where we talked about the hoped-for dawn of evidence-based treatment for advanced limb ischemia, how we could learn from the BASIL trial to design trials of the future that would help us better answer these questions. And this will take us ultimately to best CLI, I believe, today. So what did we learn from the BASIL trial? Well, a couple things. One, we learned that if you looked at just survival and amputation-free survival, overall, the two treatments looked very similar and were essentially non-significantly different, and particularly for the first 2 years. But that after 2 years, there seemed to be some divergence favoring patients who had gotten surgery first, both in terms of overall survival as well as amputation-free survival. But another important point here was that despite the nihilism of some towards this disease and towards these patients, more than 70% of patients, and this is true even today, who are currently considered candidates for revascularization are likely to live at least 2 years. So durability for these patients, while it may not be 10 or 15 years, is a significant issue because many of these patients that fail have recurrent symptoms. In the BASIL trial, they also took a look, and this is of course not randomized, at the outcomes by treatment received. And not surprisingly, they demonstrated, hearkening back to Dr. Veith's data, that patients who got their bypass with a prosthetic graft, which were about 25% of the patients in the BASIL trial, did a lot worse than patients who got a vein bypass. They also showed on the right-hand side the suggestion that patients who had their bypass as a rescue operation after failed angioplasty would be just as good may be a flawed concept. So patients who got their bypass as a secondary procedure did not have the same outcome as patients who got their bypass up front first. And this suggested to them that this was not a free shot. And the authors commented that bypass surgery with vein offered the best long-term amputation-free survival and overall survival, and that angioplasty, however, was probably superior to a prosthetic bypass, at least in their data. In the early 2000s, we also had the opportunity to conduct the PREVENT 3 trial. This was a trial designed to look at the role or potential effectiveness of a unique drug, a transcription factor decoy molecule that could be delivered in the operating room versus placebo in lower extremity bypass grafts that was conducted in over 1,400 patients. This is still the largest single trial of lower extremity vein grafts in critical limb ischemia that's been conducted. And these patients were enrolled over a 2-year period from 2001 to 2003 at 83 participating sites, of which Dr. Roddy was one of the most prolific contributors, among others. The primary endpoint of this trial, which was really focused on the drug preventing graft lesions, was non-technical graft failure, and so there was mandated aggressive duplex surveillance to identify lesions, and providers were encouraged to address those lesions with revision if they met criteria to promote secondary patency. The minimum follow-up was 1 year, and only 3% were withdrawn or lost. And just to point out a few key findings, the perioperative mortality for lower extremity bypass in these patients was 2.7%, and the early graft failure rate was 5%. I think these are quite excellent results from these vascular surgery centers in that era. This is what it looked like on the table. This was a 10-minute treatment of the vein graft after it was harvested from the body in a tube with the drug. You didn't know if it was the drug or not. It was a true blinded, randomized control trial, and then the graft was implanted. And lo and behold, after all that effort, unfortunately, the drug did not work. We generated this very disappointing curve where you couldn't draw these two lines closer together if you tried. So that was the end of that company, but it was the opening of the era of digging into the data and really understanding what happened. And so about 25% of patients had this primary trial endpoint at 1 year, and overall, about 30% of patients within the first year had some kind of clinical failure of their bypass graft. But you could see that primary assisted patency, which included duplex-based reinterventions, and secondary patency was quite excellent. Limb salvage was 87 to 89%, and the mortality rate at 1 year for this population was 15%. I think overall these results have stood the test of time and are a benchmark that can be used as we think forward. We learned many things from looking into the data from this trial. Some of the things which we already knew we were able to look at again with a larger set of multi-center data. And particularly, we looked at some of the variables that affected the technical and long-term durability outcomes of the bypass grafts. And vein quality is clearly the most important determinant of the outcome of leg bypass surgery. About 43% of the patients in the trial had what we considered an optimal conduit, which was a saphenous vein, single segment, greater than 3.5 millimeters. And for those patients, the 30-day failure rate was under 2%, and the 1-year results are shown here. But more importantly, what we again relearned is that as long as you have good runoff, it didn't matter if it was a popliteal or tibial target for a good vein. It worked equally well to popliteal or distal tibial targets, really stressing that for a good quality vein, the level of the distal anastomosis, as long as there is runoff, is really not a critical limitation. Well, now, moving into the era, that was sort of easy. We're comparing bypass grafts to bypass grafts, veins to prosthetic, but how are we going to compare open and endo? It's very challenging because they're very different techniques, and what we really need to do is have appropriate endpoint definitions and staging so that we're not comparing apples and oranges, which is what our literature, unfortunately, is full of, and where we need to kind of move past to get to true evidence-based therapies. So in the 2009, 2008 era, the SVS also got a working group together to try to develop some objective performance goals. And this was, the idea here was to develop some minimum standards to assist the FDA with allowing the evaluation of new technologies, catheter-based technologies that perhaps would not be randomized trials, to have some basic standards to compare them against. And it was here with this working group that the major adverse limb event, or MAIL, was defined as a critical endpoint, a more sensitive endpoint to the quality of revascularization than just amputation or amputation-free survival. Indeed, the need to perform major reinterventions on patients, such as treatment of acute limb ischemia with thrombolysis or thrombectomy, or the need to do a major open operation, should be evaluated as a critical measure of the effectiveness of any revascularization procedure. And so MAIL was defined by this working group at the time, and the combination of perioperative death and major adverse limb event was suggested to be probably the most important single measure of efficacy of revascularization. And using data that was pooled from BASIL, PREVENT-3, and a couple of other studies, we were able to create some statistical analyses to demonstrate some markers of both safety and effectiveness that new therapies could be compared to. And this included safety outcomes such as MACE and death that should be expected for any technology of lower extremity revascularization, should fall within a certain range of these markers of bypass surgery. And also for 1 year, developing some standard goals, objective performance goals of a new therapy along these different efficacy endpoints, including MAIL, amputation-free survival, and freedom from reinterventions. So why do we need to think about staging? It's because patients that come to us with advanced critical limb ischemia really represent a very, very wide spectrum of disease severity and clinical urgency, ranging from rest pain to small minor ulcers all the way up to wet gangrene involving much of the foot. And I think, as I showed you based on the actual definitions, these are all actually Rutherford 5. They're still salvageable, but Rutherford 5 is really a mile wide in terms of trying to look at comparative outcomes. And so it became clear also when you think about this that each of these patients might not need the same magnitude of hemodynamic improvement or durability to successfully treat their problem. So, this led to ultimately the concept of better limb staging and the SVS threatened limb classification system, which was published in 2014 with Dr. Mills and this group, where we sat down and we basically thought about the three major axes of threat of the limb, being the extent and severity of the wound that's presenting, the severity of the ischemic deficit that is present in the foot, and also the presence and extent of foot infection, which is a major driver of amputation regardless of the degree of ischemia. So this is sort of like a cancer mentality of a T&M approach to staging the limb, which we felt would have much higher resolution than the Rutherford scheme for the reasons that I outlined. So it seems a little bit daunting at first. There is an app that's available on the SVS IPG app that you can easily do this. We do this in clinic every day. We use the wound scheme. All of these three factors are graded from 0 to 3, which gives you a possible of 64 combinations. And this working group sat down and, using available data and expert consensus, basically grouped these into 4 clinical stages of severity based on the expected risk of amputation at 1 year, from very low to high, and that generates the 4 stages of disease. So like any other staging system, whether it's breast cancer or CLTI, you start out with a group of people thinking about what it should be, but they then have to go out and validate it and retest it and see if it actually allows you to segregate, not only prognosticate outcomes, but determine better treatment paths for individual patients using the staging system. And so we're still very early in that process in terms of prospective validation, and even getting Wi-Fi widely incorporated into VQI has been an ongoing effort. But it does look like it's actually very predictive of amputation risk, and this is an earlier compilation. There are now many, many more papers that looked at about 3,000 patients from different publications. All of these were reports including revascularization. You can see that Wi-Fi staging is strongly associated with the risk of amputation at 1 year, being close to 0 in stage 1 and up to around 20 to 25% for patients presenting at the most advanced stage, stage 4. So clearly, when we're comparing outcomes by the treatment that we choose, we have to take this into account, because the long-term outcomes are going to be based largely on how the patient presents, as well as on the success of our intervention. So the next step forward, I think, was the Global Vascular Guidelines effort. And this was a very large effort from an international group sitting down and getting together and trying to redefine how we should look at evidence-based treatment in this field. And in this era, I would say there was an intentional effort to try to get a little bit away from what was becoming a lesion-dominant focused thought process around advanced limb ischemia, rather than a patient and limb-centered approach. And ultimately, this document was endorsed by many societies around the globe, and I think stands right now as a good foundation for us going forward in terms of thinking about how we should treat these patients. And the foundations that we put forward in this document around the treatment of evidence-based treatment of these patients was to actually not start with the lesion, but to start with the patient. So start with assessing the patient's individual risk and goals for care, then stage the limb, and we propose the use of the SVS Wi-Fi staging system, and then finally look at the anatomic complexity of disease, similar to what I referenced with the syntax score in coronary disease, but using perhaps a new staging system. And what was suggested in this document was the global limb anatomic staging system. But the importance here was to stay organized and structured around these 3 foundational axes of determining the best way to treat patients. So risk stratification tools, we have many of those. None of them have actually been prospectively validated in all comers, large numbers of patients. They all share multiple similar elements around advanced age, coronary disease, renal failure, tissue loss. I think the current best model is the one that's been generated using VQI data by Jess Simons and colleagues, which looked at over 30,000 patients who had undergone either bypass or peripheral intervention for chronic limb-threatening ischemia, and created a risk score that allowed us to segregate patients who were most likely to have long-term survival. I would point out from this data set of over 35,000 interventions that the low-risk group was over 80% of patients. So most patients that we're currently getting revascularization, whether endo or open, in the United States at least, are of acceptable risk for surgery. And the global guideline defined a high-risk patient as one who might have an expected perioperative mortality greater than 5% or an expected 2-year survival less than 50%. Patients at this kind of high risk need to be thought about carefully in terms of their treatment options, including primary amputation and palliation, and whether or not they're even a candidate for an open operation is a question mark. So this is the beginning of an algorithm that looks kind of similar to the coronary disease algorithm that is suggested in the global vascular guidelines. So let me just walk through this a little bit. This advocates, again, right up front, for staging the patient and the limb first before we get to the anatomy. And patients who have a low-risk limb, such as stage 1, should be treated primarily with wound care and surveillance and monitored closely for deterioration, because the staging system is not perfect. There are some patients who you think are stage 1, and within a few months they turn out to be much more advanced, because we have limitations even in how we can measure ischemia. If a patient is a candidate for limb salvage, it's important to estimate their survival. I think no matter how we decide to treat patients, the first thing is to understand what's their functional capacity and what's their likelihood for long-term survival, and are they indeed a candidate for revascularization? And then finally, if they are, we need good quality imaging, including the ankle and foot for all of these patients to determine their treatment options. And then I think it's different if a patient is very high risk for surgery versus standard risk. And a standard risk patient, one should at least know the status of the vein conduit for possible bypass as you consider which option, endo or open, might be preferred for that individual patient. This is the algorithm that's suggested in the global guidelines from 2019 that I think still makes sense in clinical practice. The global limb anatomic staging system was developed intentionally to be not single lesion based, which is much of what we have with TASC and other schemes, but to be limb based, because when we revascularize a patient for limb threatening ischemia, we are looking at the entire angiogram from the top of the leg to the foot. So we need a scheme like Syntax that integrates all that. This was developed using basically expert consensus supported by evidence reviews, and it's focused on infrainguinal disease and the concept of defining a primary target artery below the knee as your primary path to revascularize that patient. In this scheme, you separately grade the above knee and the below knee segments, and then they're combined into 3 overall levels of complexity for revascularization from an endovascular mindset. So low complexity disease would have a very low expected technical failure rate and a reasonable 1-year limb-based patency, up to high complexity disease where expected technical failure rates would be higher, and we would not expect to have a successful 1-year target artery path widely patent in maybe 50% or less. So I'm not going to go through it in detail, but like other schemes, in terms of the grading, it's based on the location, the length, and the severity of the stenosis versus occlusion, both in the femoral popliteal segment and in the below knee segment. And then you can combine these, and this is also an app that's available online through the SVS, and you can get the expected complexity from low complexity stage 1 to high complexity stage 3. And there's now, I counted more than 50 publications already out there that have largely used the GLASS system and essentially validated that it does predict the outcomes, particularly of endovascular intervention, both in terms of early technical failure as well as durability. This is a reanalysis of the basal data through the lens of GLASS conducted by Dr. Kodama and Dr. Bradbury and their colleagues, demonstrating that for patients who had undergone endovascular intervention, that those who had GLASS stage 3 disease were significantly inferior in their long-term outcomes, including major adverse limb event as well as amputation. And then when focusing specifically on the patients with the high complexity pattern, there's a significant difference, as you can see, in major adverse limb events, favoring those patients who got bypass surgery up front versus those who had gotten endovascular therapy. This is data from the early basal trial, and many would argue the most modern and best endovascular techniques were not employed in that era, and that's a valid argument. Other studies, including this from the BI Deaconess, looking now backwards retrospectively in something like 1,200 cases, and several other papers have since demonstrated that the GLASS system is likely to be a good lens to view anatomic complexity in CLTI. Here again, looking at stage 1 through stage 3 on the left-hand side, you can see that the incidence of reintervention, amputation, or stenosis goes up with complexity, and you can see again when comparing those patients who underwent endovascular intervention versus bypass at their center for glass stage 3 disease, there's a quite significant spread of those curves favoring open bypass for more complex disease. So with that as a background, that takes us to the exciting publication of Best CLI and the landmark effort by Alec Farber, Matt Menard, and many others in the Best CLI trial. But really, the passion, dedication of Alec and Matt cannot be overstated in making this a reality over almost a decade, and much more to come still from this trial, which is very exciting. So again, vascular surgeons taking the lead, designing and executed science that is practice-changing science by surgeons needs to be recognized. So what was the Best CLI trial? Well, I think in many ways it took all the lessons that I just digested for you over about 20, 30 years and rolled it into the design of this trial. A prospective, randomized, multi-center trial, open label, pragmatic, to compare clinical effectiveness, functional outcomes, and cost in patients with CLTI and infrainguinal disease who were candidates for either open bypass or for endovascular therapy. This trial was sponsored by the NHLBI and also ultimately supported by many other groups and industry to help execute the long-term follow-up that was required for the data. So this is an important slide so people can really understand the trial, and the study was really designed with the knowledge of everything we just went through. Firstly, that we should have a strict definition for what CLTI was to include patients in the study, corroborated by hemodynamic measurements. The patients need to be at acceptable risk for open surgery and considered by two different investigators, both an open surgery operator and an endo operator, that their anatomy made them eligible for either type of revascularization. Secondly, we've known for many years that you can identify a good quality saphenous vein based on vein mapping preoperatively, and that the need to use a prosthetic or alternative vein bypass is a significantly inferior surgical outcome. So right up front, this was designed as two parallel trials based on the availability of saphenous vein into two cohorts, one group with likely good saphenous vein and the other requiring alternative conduits. Following that, patients were then stratified by the other important factors that we know affect outcomes, including rest pain versus tissue loss and the presence of significant below-the-knee disease. Stratification is important because it means that there will be balance in the randomization across these critical factors. These two parallel cohorts were then stratified and randomized to getting either an endovascular or surgical approach. It's also important to understand that this trial was specifically designed so that in each of these cohorts there was an opposite hypothesis. So in cohort 1, the patients with vein were hypothesized to have an outcome that would outperform endovascular therapy, whereas in cohort 2, the opposite hypothesis was in place, that endovascular would outperform alternative conduits. And each of these was separately powered statistically to ask this question. The endpoints, the primary endpoint for the trial, based on what I showed you and the performance goals that were outlined from the SVS, was major adverse limb event-free survival. So this included all-cause death at any time, above ankle amputation, and the first major reintervention, which was adjudicated by an independent clinical events committee. The safety endpoints include mortality, MI and stroke. MI and stroke were also adjudicated by an independent clinical events committee. Secondary endpoints, many of which are still going to be coming to you in the coming months, included all of these listed on this slide, many of the components of the primary endpoint, but also several others of interest and some novel ones, including freedom from clinical failure, freedom from recurrent CLTI, and also the total number and magnitude of reinterventions. This trial involved over 1,000 investigators across the U.S., Canada, and also some outside in Europe as well. The 72% of them were vascular surgeons, but this is a truly multi-specialty trial. It involved cardiologists, radiologists, and others. And let's get into the data. Most of you are aware of the results, but I just want to highlight a few of the key findings. So in cohort 1, There were 1,434 patients who had an available saphenous vein graft based on preoperative assessment who were randomized to either open or endovascular. You can see there were very few crossovers on the right-hand side, some from surgery to endo, about 3%. The median follow-up was 2.7 years with a maximum of 7 years. There was some significant loss to follow-up, which is typical for CLTI trials over the long term. And so the demographic characteristics are pretty standard for patients that we treat with advanced CLTI. You can see in the trial that about 80% of the patients in this cohort were treated for tissue loss, that the prevalence of diabetes was over 70%. There was about 10% with end-stage renal disease. So this is a true CLTI population. What procedures were done? Well, for open bypass surgery, FemPop and FemTib bypasses were the dominant, and there was a significant number of popliteal to tibial and pedal bypasses as well, 698 individual procedures. For the endovascular interventions, this has been a little confusing in the report because they're reported based on procedures based on each individual segment that was treated. So there's 1,250 procedures in those 700 patients. The majority and the usual spread, including almost 400 below-the-knee interventions. What types of interventions were done? On this slide, you can see that it depended on the level of the segment being treated, which is to be expected because in the below-knee arteries, still plain balloon angioplasty is still essentially standard of care, which is in red. You can see that in the superficial femoral artery, there's a significant amount of drug-eluting technology as well as stenting. And as we move down the segments, and I think this is, reflective of current practice, we get more down into plain balloon angioplasty. But it's important to note that on a per limb basis, not a per segment basis, less than 20% of patients in both cohorts were treated with angioplasty alone on a per limb basis. And this table from the publication summarizes the primary results of cohort 1, which were statistically significant across the primary endpoint of male or all-cause death favoring surgery with a 32% risk reduction, including the individual components of either major reintervention, which was dramatically different, 65% risk reduction, and also major above-ankle amputation. There was no difference in all-cause mortality at any time, peri-procedural or long-term, in cohort 1. Looking at each of these individually, this is the primary study endpoint of male-free survival. You can see that these curves begin to separate relatively early, but they continue to separate over the course of the first year, after which they become somewhat parallel. This is the time to the first event in this trial, which is the primary endpoint. Looking at major reinterventions in the trial, which included conversion to open bypass as well as treatment with thrombolysis or thrombectomy, you can see again the curves start separating very early, but they're continuing to separate over the first 6 to 9 months, and they're actually still at a different slope, even longer term. Above ankle amputation also was significantly reduced in the patients who received surgery up front. This is statistically significant at 0.02, although the absolute risk reduction is only about 3.5%, at least at the median time of follow-up. And no difference in mortality, which I think to some may have been somewhat surprising. This is a striking, I think, downstream, cumulative effect of not just the first intervention, but the total burden of care, the total number of major reinterventions based on how patients were randomized in the trial. So more than twice the number of total major reinterventions were borne by the patients who started out with the endovascular approach in this cohort compared to open surgery. And this really begins to reflect the overall long-term burden of care. Most of these patients were not treated or reintervened upon for asymptomatic findings, I would expect, but mostly because of significant either failure to resolve their presenting symptom or recurrence of their CLTI. Looking at a forest plot, the superior results for the group favoring open surgery in cohort 1 was seen across almost every factor, with a few exceptions being non-white race and end-stage renal disease and prior revascularization or secondary revascularizations. Those confidence intervals cross 1. So those might be areas where you can be less sure about this outcome. Major adverse cardiovascular events were actually not different over the course of the trial, and actually in the long term were numerically higher in the group assigned to endo first, but they were not statistically significant. I think this was surprising to many people, but I think reflected the excellence of medical therapy that was provided to patients in the BEST CLI trial across all centers. And then in cohort 2, just to summarize the top line, result on the major endpoint, there was no statistically significant difference in the patients who had alternative conduits, although there were strong signs of reduced major reinterventions. The composite male or all-cause death endpoint was not different. So there are important limitations to the BEST CLI trial. Any trial can only begin to answer certain questions and raises many others. But I think it's currently the standard landmark trial in our field from which we can launch forward with true evidence-based guidelines and approach. So pragmatic design allowed for possible selection and operator bias, and not only in enrollment, but in picking which procedure to do. Many techniques were applied. The endovascular techniques are not standardized. People were allowed to do whatever they felt they wanted to do in their approach to the disease. Equipoise and eligibility were determined at each site locally and may be variable in different people's eyes. So we await the further analysis of the trial to really understand what types of patients were in the trial in terms of anatomy with more detail. Cohort 2 was likely underpowered, and the percentage of female patients was a bit lower than targeted. Also, during the trial enrollment, we had the whole issue with the question about paclitaxel mortality from the Katsanos report that led to some potentially lower use of drug elution in the middle of the trial, but overall, 50% and 52% of the endo-treated patients in cohorts 1 and 2 did receive drug elution, which is about what VQI data says overall for peripheral intervention. So what were some of the key clinical outcomes from this trial? So I think it's very clear in terms of how we look at the results in cohort 1, that for CLTI patients who are suitable for either open or endo and who have an adequate saphenous vein, open bypass was significantly more effective. It was significantly more effective in many ways. 32% reduction in mail or death, 65% reduction in major reinterventions, 27% reduction in major amputation, less than half the total number of major reinterventions over time, and about a 20% reduction in recurrent CLTI events. The benefit of open revascularization in this cohort, in this trial, was evident across virtually every subgroup. So what are the take-home points? I think it's really clear that an endo first, or even more strikingly, an endo-only approach to all patients with CLTI is simply not evidence-based care. And centers of excellence must be skilled at both techniques of revascularization. Furthermore, informed decision-making with patients in this field should include the results of this evidence, and suitable patients should be offered the option of open bypass surgery, which I suspect is being under-offered and underutilized in current practice. And I think this trial should make that begin to change. It's not surprising and shouldn't be surprising to us that there are trade-offs between effectiveness and invasiveness. This is common in medicine and surgery, and as I showed you, it's common in coronary artery disease. We need to embrace it and accept it. But I would suggest to you one of the differences between coronary disease and vascular disease is that as vascular surgeons doing both of these things, we have the opportunity to make these decisions, but that could be either an advantage or a burden, because we all have settled into our ways and our workflows and may be unwilling to reconsider or change what we currently do in practice. And I would suggest to you that centers who are doing less than 20% bypass in CLTI should really probably take stock about whether this is the best treatment for these patients. This is the graphic from the Global Vascular Guidelines that was published before the BEST CLI trial, which basically suggests that based on the limb threat severity and the anatomic complexity, some patients may be better served if they are surgical candidates and have a vein with an open bypass, and some for endovascular, and many are indeterminate. We can't fill this grid in yet from BEST CLI because we don't have the level of complexity of the anatomic data. But I think that this graphic is still likely to be a reasonable benchmark thinking forward and based on what we're seeing with BEST CLI. So in conclusion, vascular surgeons who treat these patients more than anyone else by far, who are consulted on these patients more than anyone else by far, and for whom these patients are really a bedrock of our practice, have led the way in evidence-based revascularization and care of the CLTI patient. The foundations of evidence-based revascularization require sticking to definitions, require accurate staging, and require consistent endpoint measurements. Randomized controlled trials are not the only way to get the evidence, but they're important. They're difficult to conduct, they have limitations of generalizability, but they do provide the strongest level of evidence to compare treatments. I actually think that this generic open versus endo debate is tiresome, oversimplified, and has actually been harmful. Harmful for our specialty and possibly even to our patients because it lacks the nuance with which we know we need to make clinical decisions in these patients. Optimal care should be stratified by the known factors that inform how we expect these patients to do after these treatments, and informed decision-making with patients should include offering them the options with the best available evidence. We can and will pursue evidence-based practice and still innovate at the same time. These are not mutually exclusive. That's a myth. Future studies should focus on specific, well-defined subgroups and pragmatic trial designs, and perhaps the use of large data and AI may help better define patient-specific approaches. I thank you for your time and attention and really enjoyed the opportunity to join you at the meeting.
Thank you, Mike, for a wonderful talk and a comprehensive review of the literature. So happy that you accepted the invitation to speak. I have to say, back in the late 90s when we were together at Yale, I could never picture the two of us being on this podium in front of such an esteemed audience. As a token of our appreciation, we'd like to present to you a certificate which just 2023 Distinguished Visiting Professor to Michael Conti for his talk today. Thank you.